The evolution of breast cancer treatment has really become a revolution thanks to refined surgical techniques. And joining me today to discuss more about these surgery techniques is Dr. Susan Boolbol, Chief of Breast Surgery at Mount Sinai Beth Israel. Dr. Boolbol, thank you for being here today.
Well, thank you.
When a patient is diagnosed with breast cancer, at what point do they see a surgeon?
Well, it's an interesting question. There's several points that a patient can see a breast surgeon, all of which are very important. One of the more common reasons why women will see a breast surgeon over their lifetime, or any doctor, believe it or not, is breast pain. It's a really common thing. So women see breast surgeons for anything from breast pain all the way through to cancer, and lots of things in the middle. Abnormal mammograms, breast lesions that are not cancer but are abnormal and require excision, findings on their breast of any sort, masses that they may find or their doctor may find. So there's lots of steps along the way, even before cancer, even without cancer, that a woman can be referred to a breast surgeon for. With a diagnosis of breast cancer, I actually think the ideal time for a woman to be referred to a breast surgeon is when they have an abnormal mammogram. A breast surgeon can explain what is really going on. If that doesn't happen, a lot of times women get their screening mammogram, which is their yearly mammogram. They're not having any symptoms. It's just a routine mammogram. If that's abnormal, they get the letter in the mail, the dreaded letter in the mail saying, "There's something abnormal, please call, we need to do some more pictures." At that point, that's the ideal time for a referral to a breast surgeon, because the breast surgeon can then explain what's going on and really de-escalate the emotional situation that the woman's going through. It is an incredibly emotional time. From that letter from the first abnormal mammogram, or if they feel something abnormal, it's incredibly emotional. Now, the good thing is, most of the time, abnormal mammograms or breast masses that a woman feels or her physician feels are not cancer. But up to the point where they find out that it is not cancer, it is incredibly emotional. And the support of speaking to a breast surgeon who does this every day is really incredibly important. If a woman is not referred to a breast surgeon with that abnormal mammogram, and the radiologist does additional pictures, and then she's told that she needs a biopsy, again, another critical point for a referral to a breast surgeon. The breast surgeon can go through what are the possible findings. Really, that's incredibly important. Well, what can I expect? Because in this situation, it's really about expectations. Chances are that it's nothing, meaning normal, benign, meaning not cancer findings, or our chances are that it's cancer. And frequently we can have an indication as to which side it will fall on just from looking at the mammogram or ultrasound. So another really important part is when a woman is told that she needs a biopsy with the mammogram machine or the ultrasound machine or an MRI. If at that point she's not referred, then after the diagnosis is received, either that it's atypical or abnormal cells and she may need that removed, or cancer, then absolutely, beyond the shadow of a doubt, that at that moment she needs to be referred to a breast surgeon.
So it sounds to me like you see a big role of a breast surgeon is to really be an educator for women.
Absolutely. I consider more than half my job is just educating patients and other physicians, not just patients.
Tell me about that. What is your role in educating other physicians?
Well, the reality is, of every physician out there, any specialty out there, breast surgeons have the most training in not only breast cancer, but benign breast disease, meaning not cancer. Again, anywhere from breast pain to I have a family history of breast cancer or ovarian cancer, putting me at increased risk, or to abnormal findings, or to a rash on my breast. That's the role of the breast surgeon. Anything to do with breast disease.
Are you concerned then that maybe a lot of women are not getting to the surgeon and getting that support that they need? They're not getting there soon enough?
Yes, and it's not only the support that they need, it's the education that they need. Because think about this. If you go to a physician and you learn something new about a mammogram that you were not aware of, or something new about breast disease in general that you were not aware of, you will then go and talk to your sister or your friend, or someone will say, I had an abnormal mammogram and they told me to come back in 6 months. I'm really nervous. And you just went through this. And you say, no, this is what it's about. You should speak to your doctor, but this is what I learned. So for every woman that we can educate, the reality is we're educating many, many more.
That's wonderful. Now, let's talk about some of the developments that have refined breast cancer surgery. In particular, there's something called hidden scar surgery. What is that?
Hidden scar surgery, really, it really takes into account what we call oncoplastic surgery, which is not, it has to do more with how the breast will look after surgery. And the reality of this is that most women, the overwhelming majority of women who have breast cancer, will unfortunately get their diagnosis of breast cancer, then go through whatever treatment they need for breast cancer. But we know that the reality is the overwhelming majority of women who have breast cancer will go through whatever treatment they need and never have another problem from breast cancer again. If their breast looks deformed in any way, emotionally, it's very difficult for them to get past breast cancer. Because every morning, most of us get up, we shower, there's a bathroom start that again. The reality is most of us get up, we shower every day, and there's a mirror in every bathroom. If, when you look in that mirror, if your breast is deformed, emotionally, every day, breast cancer is with you. 1 year later, 3 years later, 5 years later, 10 years later, physically you're fine. So if I can get you past the physical point of dealing with the breast cancer, but I've not helped you emotionally, I haven't done that much good. So the hidden scar program is about hiding the scars and the oncoplastic part of the surgery. So with the lumpectomy, I remove the cancer, but I've also removed breast tissue. Breast tissue does not grow back, so I don't want to leave a hole in the breast where then on the skin you see a big divot. So oncoplastic surgery is how we fill that in and really restore the cosmetic appearance of the breast. And one of the more important things is maintaining the shape and the contour of the breast, but also hiding the location of the scar, so that when you look at the breast, the first thing you see is the scar. We don't want that. We want the scar hidden. So putting the scar in a more cosmetically acceptable location, for instance, underneath the breast, what we call the inframammary fold, right underneath the breast. If we can make the scar there, and that's where we place the incision, you rarely will see that. So, and when we do the oncoplastics, maintaining the shape and the contour of the breast, so now we've maintained the shape and the contour of the breast and hidden the scar. Emotionally, it's much easier for a woman to move past having breast cancer.
Are there developments in your field that have improved women's outcomes in terms of survival and odds of beating breast cancer?
Yeah, the amazing thing about breast cancer is the speed at which change is made. If we look at breast cancer 40 years ago, it was a completely different disease. Look at breast cancer in the 1970s, even in the 80s, every woman had a mastectomy. Even for that much breast cancer, 2 millimeters of breast cancer, which they rarely picked up at that point, but even for the smallest breast cancers that they picked up, everyone had a mastectomy. Everyone had the lymph nodes underneath their arm removed. That's no longer done. Thankfully, what we've realized for breast surgery part of the overall treatment is frequently less is more. We don't have to do that. We don't have to do mastectomies on most women. It's unusual that a woman needs a mastectomy now. And when I say unusual, I mean the minority of the times. It's not rare. We do them all the time. But the norm is the majority of women today in the United States are able to undergo a lumpectomy.
You said change in your field happens very quickly. What's on the horizon that you're excited about that you think could be promising for breast cancer patients?
I think that change in the field of breast cancer, similar to many other diseases, comes through clinical trials. And without clinical trials, we won't and we would not have been able to make change. So we need to prove that a new therapy or treatment works. So the clinical trial arena really is the important arena within medicine. The problem is women, men, everyone in our communities frequently feel, I don't want to be in a clinical trial, I don't want to be a guinea pig. Well, it's not a guinea pig because the options in a clinical trial, whether you have this treatment or that treatment, are safe. And that's the important thing, is everything that we're doing is safe, but we want to see is one treatment better than the other. If we did not have clinical trials, every woman would still be getting a mastectomy, and we would never be doing lumpectomies. The reason why today most women undergo a lumpectomy is because years ago, women were brave enough and physicians were brave enough to enter women into clinical trials, and women participated in clinical trials where we proved that a lumpectomy plus radiation is equally as safe as a mastectomy, and that overall survival is the same. If we did not have a clinical trial proving that, there's no way that we would be able to offer that to women today. So clinical trials really afford us the possibility for change. There are clinical trials going on in every area of breast cancer treatment, from imaging to surgery to medical oncology and radiation oncology. So just about every area of treatment in breast cancer today has clinical trials.
As a surgeon, what do you find most rewarding about the work that you do?
You know, for most of us, this is a personal journey. For most of us in breast cancer, we're in it for a reason. Someone in our family, people that we know, and for me, every patient that I look at, they're either my mom or my sister or my grandmother or my aunt or my cousin. So I can relate to all of my patients on some personal level. It's incredibly rewarding to see a patient at their low of a new diagnosis of breast cancer and really travel through the journey of treatment with them and follow them for years and years. And that is the most rewarding part of my job.
Dr. Susan Boolbol from Mount Sinai Beth Israel Medical Center, thank you so much for being with us.
Thank you.